morning, everybody. Thank you, Tim. I'm Clark Barano, Assistant VP of Government Affairs and Policy at the MSV. We're here today along with our friends at VDH talking about the COVID-19 pandemic and testing here in Virginia. The MSV is obviously happy to partner with VDH to provide an update and keep the physician community informed. Today's webinar is going to be broken down into two portions. We'll begin with a presentation that's going to cover COVID-19 updates, including the status of the pandemic, infection prevention, and rapid point of care testing. Following their presentation, we'll be hosting a Q&A session about COVID-19 testing in Virginia with Dr. Brooke Rossheim, Public Health Physician Specialist, Dr. Amy Mathers, Associate Professor of Medicine and Pathology at the UVA School of Medicine, Dr. Rehab Adalfada, Clinical Investigations Consultant at VDH, Elward, Senior Advisor with the Virginia Department of Medical Assistance Services and MSV board member. We're thrilled to have these distinguished guests with an abundance of experience joining us to help answer questions. Before we start, we're going to remind everyone that the MSV has done a heck of a lot of work over the past many weeks relating to the pandemic and trying to give you as much information as possible relating to COVID-19. You can find all of that at msv.org/COVID-19. As this is a CME accredited webinar, I'm going to go ahead and read the following statements to make it official. It's a bit long, but hang with me. So no commercial support was received for this activity. There are no reported conflicts of interest for any individual in a position to control the content of this program or speakers presenting in the program. In support of improving patient care, this activity has been planned and implemented by the Medical Society of Virginia and VCU Health. VCU Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for healthcare team. VCU Health designates this live activity for a maximum of 1 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in this activity. If you connected to the webinar through the link that was sent to you and typed in your name today when joining, we, the MSV, have a record of your attendance. We're going to be sending that list to VCU. We'll email you to access your CME certificate. Please allow 2 weeks for all of this to get done. If you've registered but are calling to access the webinar, we will reach out to you to verify your attendance. We have a lot of people on the webinar today, and we understand there will be several questions. We ask you to keep your questions on topics addressed today relating to the pandemic. And if we do not get to your question, or if you have a question after the fact, you can always email myself or our team at governmentaffairs@msv.org. With the logistics now out of the way, please welcome the team of presenters from VDH.
Can you all hear me?
Yes, sir.
Okay. My name is Brooke Rossheim. I'm a public health physician specialist with VDH. I apologize up front, excuse me, that I'm having camera issues, so I couldn't get the camera to work, so yeah, I tried, but it's not happening. So I wanted to start with an update on the pandemic status. If you go to the next slide, please. And one more, please. So just wanted to give a brief overview of COVID-19. This emerged and was identified in Wuhan, China in December 2019. It is caused by the virus SARS-CoV-2. And in terms of the spread, you know, a travel-related case of COVID-19 was first reported in the U.S. on January 21, 2020, and then subsequently on March 11, 2020, WHO declared COVID-19 as a global pandemic. Excuse me. And just to give you some idea of the scope of this, as of November 4, WHO reports that there are more than 47 million cases and 1.2 million deaths globally due to COVID-19, and that does include the U.S. Can I have the next slide, please? So if we look at national data from the U.S., from CDC as of November 4, we see that there are 9.3 million reported cases. You can see that in the reporting period before that, 88,000 new cases, 231,988 total reported deaths, with 1,095 new deaths. And, excuse me, if you look at the map, you've got two maps there. The map in the upper right shows cases reported to the CDC in the 7 days before November 4th, and the darker the blue is, means more cases. And you can see the legend at the bottom. It's pretty hard to read because it's so small. The bottom map shows the number of deaths reported to CDC in the 7 days before November 4, and it looks like the legend has been kind of cut off. But again, the darker the blue is higher number of deaths. Next slide. If we look at Virginia data, what we see is that as of November 5, yesterday, 187,202 cases, 12,865 hospitalizations, 3,688 deaths. Again, if you look at the map in the upper right, you will see count data for cases, and you can see that cases are all throughout the Commonwealth. In the darkest blue, you do see areas. These are areas where there are the highest number of cases. And then in the bottom map, you see count data for deaths. And what you see is, again, they're spread out throughout the Commonwealth, but you do see higher pockets of deaths in Northern Virginia, Central Virginia, Eastern Virginia, and then a couple of localities that are along the border with North Carolina. So just to provide that overview. Next slide. So as far as testing goes, CDC used to have this nice trend, graph that showed the trend of testing over time, and then they got rid of that. So that was unfortunate. So total number of tests reported, 152,599,000. Positive tests, 11.1 million. So nationally, excuse me. Sorry, this is allergy stuff. I don't think it's COVID-19. Nationally, you've got a positivity rate of 7.3%. Next slide. And then if you look at Virginia data in terms of testing, you can see that the number of tests have steadily gone up. Now, this is only PCR testing, and you can see that we're up to 2.7 million testing encounters. And then the yellow line is, you see the 7-day positivity rate. And right now, we are at 5.8%. And a couple of things that I would point out from this slide is, first of all, that over about the past month, you see that line of positivity has been creeping upward. So it's kind of gone up from 5-ish% to a little more than 5%. Now we're up to 5.8%. So that's something that we are definitely taking note of. The other thing I would point out is that when you look at the number of tests being done, we are achieving 15,000 and over 15,000 every day. So this is, we're having a good amount of testing done. Next slide. And at this point, I'm going to turn it over to Dr. Elward to talk about infection prevention and control issues.
Hi, thanks, Brooke. Great job. Yeah, next slide, please. Yeah, a couple things we're going to talk about is how to, the dynamics of prevention and where we need to be really careful at this point in the, in the process. Prevention fatigue and things that are going to slip by. One of the things that this slide shows is looking at outbreaks. So these are not admissions. Those are going up as well, as Dr. Rossheim mentioned. But you'd see an increase, particularly in acute care hospitals, of outbreaks. And there is similar data looking at nursing homes and some outpatient practices as well. So the message here is that we are seeing some increases in outbreaks within the institutions. And that means we all need to be very, very careful about what we are doing as individuals. Next slide. Now, what patterns seem to be recognized during the outbreaks? Well, in general, it relates to some relaxed adherence to recommended infection control and prevention practices. PPE usage, things that are reused, not sterilized, using soiled PPE, things like that. Physical distancing in break rooms. It's really important to make sure that we consider physical distancing everywhere. People can tend to congregate in break rooms instead of cycling through and thinking about the fact that they're now a foot away waiting for the microwave rather than 6 feet away. And social distancing before and after work. Unfortunately or fortunately, it is our privilege, I would say, as healthcare providers and clinicians to be on the clock regarding COVID. So what we do before and after work may make a big deal and may have a big influence on what we do during work. There have been return of furloughed staff who are not trained or perhaps not retrained. If they were off for a few months and then come back in, they may really need a refresher in COVID-19 practices. And some of that has not been happening. People have tried to relax visitation guidelines, and those could be done, but they need to be very carefully evaluated. And I couldn't see my newborn granddaughter after I delivered 700 babies at our local hospital, but that was a good thing, that only the dad and mom got to be in the hospital. So, we really need to be careful about that. And returning of sick or exposed clinicians. That's another area that can break down, or clinicians that don't really recognize their own symptoms and so don't practice what they preach, so to speak. So next slide. It's really important to enforce social distancing between staff in common areas. We might suggest that you have your staff in the hospital or your office decide together on how they're going to handle it. Make it their job. They're more likely to do that than if they see it coming from higher up, but engage them in that decision and that process. It's important to routinely educate staff and re-educate them on the proper use of PPE. There's some really excellent resources at the CDC on things such as aerosol generating procedures. There'll be some other links later in the presentation. The CDC has some excellent resources, and particularly for those of you in primary care who are hearing about plans to how to handle Thanksgiving or Christmas or holidays, things like other holidays. They have some really, really good stuff that you can use and your patients can use. CDC emphasizes that staff shouldn't be extending use or reusing PPE supply if supplies have been restored. Many people are putting the masks in their pocket, or they're hanging them up. They're using them for a week or two at a time. Really be careful about extending use or reusing PPE. Do it smart, or don't do, or get new. Implementing enhanced infection control rounds for in-hospital, just review in your office, so we can monitor and validate PPE and hand hygiene compliance. In almost every situation, be sure that the products you're using for environmental cleaning are effective against not only COVID, but also against multi-drug resistant organisms. The Don't be shy about asking for PPE, and don't be shy about documenting you're asking for PPE. I know some places are shorter than others, but really keep after it so that they can generate their needs to VDH and other authorities. And also think about what could be better in your office. Look for what people are doing well. Consider having teams of staff where they can get together and go around and say, is this what we want to do? You know, be accountable to each other. That is very, very important. And it's a very successful way of reinforcing the education that's made available and reinforcing the implementation and supporting implementation. Next slide. It's important to review employee health policies, especially return to work criteria and following VDH guidance, which has been recently updated on managing exposed or asymptomatic clinicians. Continuing to implement universal source control and particularly mask protocols for staff, patients, and visitors. Continuing to screen and monitor staff for signs and symptoms of COVID-19. We do that in my office every day. A couple of days, I didn't get screened. And so I take initiative and walk up and say, hey, take my temperature. You'll make their job easier and you'll make sure everybody's complying. Reviewing visitation policies are very important, making sure that visitors and non-essential personnel are screened and educated on IPC practices. It's important to evaluate the process of transferring information regarding a patient's COVID-19 status. Most of those are pretty well greased, but make sure that when people have COVID or being tested, that people know about that in your system. And there should be within everyone's system a way of communicating that. And immediately notifying the local health department when a suspected outbreak is occurring. That may mean the local health department hears from 3 people, but it's better than hearing from no one. And it's really vital to get to know the really excellent people at your local health department and report outbreaks early to prevent or provide timely and effective responses and prevent spread. Next slide. It's very important to remain vigilant about procedures. Busy days are important days, in that it is clear from studies of ICUs and other environments that the busier you get, the more measures seem to break down. And that's very important to realize that, you know, all of us are seeing a lot of patients right now. And the busier you get, it's still worth the time to make sure you're following protocols. Again, ask and ensure to the best extent possible that you have supplies of PPE such as masks, gowns, gloves, hand soap, alcohol-based sanitizer. If you happen to be shipped sanitizer that feels really gooey on your hands and you don't like, and people may not be using it. So be cognizant of and ask for feedback on what's being made available. And if it's things that people are using, don't like, and how to help them use what they have, first of all, and get better resources if possible. It's also very important to use PPE appropriately. Again, the CDC document about personal protective equipment has some really great stuff on there. And continue to ask and obtain N95 respirators, especially if people are going to start doing point of care testing that Dr. Mathers will talk about later on. It's going to be very important to make sure that you have what you need to do that testing efficiently. Some things I've mentioned that you really need to be vigilant about in terms of infection control measures is avoid touching your mask. A lot of people take it on and off, they put it in their pocket. Really be careful about that and avoid it if all possible. Think about the personal items you might bring in and watch which items your staff may bring in or even wear. We know that makeup and jewelry and things like that can impair the effectiveness of personal protective equipment. And so it's really, really important to make sure that we're following the measures that we know work. In addition, it's not a bad idea to review how to wash your hands. The fingertips are missed about 48% of the time, the middle of the palm 30%, the back of the hand about 30%. So washing your hands means washing the entire hand. And unfortunately, we don't always always do the job that we would like. But remembering those little things can make a big difference. Masks do seem to work. It will reduce your risk of COVID by about 6-fold, and it's worth the effort to use and use correctly. Next slide. Now, one question that has come up is, does wearing glasses protect clinicians from getting COVID? There's actually a very nice review of measures in Lancet. I'll talk about the most recent study published in September in JAMA Ophthalmology. They saw some differences in admission of persons who wore glasses who didn't. There are 13 unadjusted studies, unfortunately only 3,700 persons, but they do indicate a decrease in the risk of COVID, 5% compared to 17%. Now, from an epidemiologic perspective, again, association does not mean causation. And all the studies out there, including this observational study, are unadjusted. Hopefully more will come in. But I would say that protective eyewear should be encouraged. And if you're going to wear it, wear good protective eyewear. Reading glasses are probably not sufficient. Gaps between glasses and the face likely don't protect us. What they really may be doing is protecting us from touching our eyes and spreading it into our system that way. It's unlikely that COVID in the eyes flows out into the environment. That may happen, but we don't know. But it's very likely that without glasses, we'll touch our eyes much more. And if you are worried about an individual patient with COVID, make sure you're using very good glasses that are designed for protection. Think about face shields. Those will actually may be more efficient and more easy for people to use, less likely to fog up. The bottom line is think really careful about what you're doing, and encourage wearing glasses in any situation where you think there might be some risk. I'll turn it over. I'll turn the presentation over. Thank you very much.
Hi, Amy Mathers, University of Virginia. So I was going to just touch briefly on sort of what's coming down the pipeline for antigen testing, because we're about to get flooded with them. So next slide. So I thought I would just quickly frame it as a case, because I think what's being asked about testing for COVID is somewhat unique in practice. And we're having to do a lot more infectious disease in contact tracing than we're used to, rather than diagnostic testing, but we're doing both. And so I thought this was sort of a typical case of somebody who comes to your office for a med check or for some other reason and wants a COVID test. And so kind of what do you tell her? Should she get tested? Does it help you before travel? Which test should you use? Next slide. And so I think it's important to just kind of verbally state that there's different types of ways to test for infectious disease. One is for what we're used to is testing for an infectious disease in the person who's in your office or who's in the hospital in front of you to see if they're infected. And so that's diagnostic testing. Just like all other infectious disease diagnoses, COVID has a constellation of symptoms. And so if you have a symptomatic patient, you test them at that time. First off, it's very, very helpful to do that, because most of the PCR tests are actually quite sensitive and will tell you whether or not the patient's symptoms are attributable to COVID or not. And so very, very helpful piece of information. You can sort of move on from that without a lot of repeat testing that we did early on in COVID. The other type of testing is epidemiologic testing, and that's sort of illustrated in the case of the person who comes to you and says, I want to get tested before I go see my mother. And this is the idea of you're not really testing for the benefit necessarily of the person in front of you, or maybe you are, but it's to limit further spread. And so when are we doing, or when do we need to think about epidemiologic testing for SARS-CoV-2? And it's in high-risk situations where secondary cases can occur. Another instant, we're trying to find asymptomatic persons who are carrying in a group of people, or in a setting where they've been at high risk for exposure. and or testing just for complete surveillance, such as in the long-term care is what's been suggested. Next slide. So there's a lot of tests. So when I went to the FDA EUA website, I think I searched this correctly, but it looks like there's 158 FDA evaluated tests and 7 antigen tests for diagnostics. I'm not going to talk about antibody testing today. I wanted to really focus on sort of the diagnostic tests that are out there to diagnose somebody with COVID infection right now. Remembering that there's actually not an FDA cleared test for coronavirus. It would be great if some of these companies were able to get a packet together to actually do a full submission to the FDA so that we had an FDA approved platform, but we don't. They come in all sort of shapes and sizes. And I think that, as many of you have heard, but I'll just refresh, the reason we use one over the other is not necessarily driven by pure science or performance, which is what it would be in a perfect world. In my opinion, it's driven by cost. Supply availability is probably one of the primary drivers. Turnaround time is really, really critical. You know, during the summer when we were seeing turnaround times upwards of 10 days, that's not a helpful test. And then point of care testing, obviously the turnaround time is ideal. You can tell your patient something right then and there. What type of specimen? You know, we've had swab shortages. And so the ability to collect specimens with or without a swab, such as saliva, and then performance. Next slide. So with all that in mind and not going into the details, and if anybody wants to ask specific questions about sort of some of the different things to consider when you're thinking about a PCR test or versus an antigen, I just wanted to make sure everybody had a kind of primer on what's coming with the antigen tests. So the antigen tests that are coming or that are actually here are point of care tests. And there's 3 primary ones that we're seeing in Virginia: the Sofia Quidel, the BD Veritor, and the Binax Now. And I have no affiliation or opinion about one over the other necessarily, but it's important to remember the Binax Now is a little card that doesn't require a reader. They all take about 15 minutes, and they all come with a nasal swab that you use and put into the instrument right then and there. They all have EUA only approval, and they're all only approved in symptomatic persons. So, and it's not just symptomatic persons, it's symptomatic persons within the first, 5 to 7. There's one that I'm not going to talk about today that's all the way out to 12, but really it's 5 to 7 days for the 3 that I'm focusing on, where we're going to see the largest volume. So symptoms within that time, with the idea that you're shedding so much virus during that time that a less sensitive test can actually capture that person. And so here was the package insert. So 209 patients were evaluated for the EUA clearance for the FDA. And for the Sofia Quidel, which I have the most data on, there was a sensitivity of 96%. So at UVA, we brought this in and we did a validation in symptomatic university students. So kids coming in as soon as they had symptoms, so early within that 5 days. And go ahead and click. This work was done by others, Lindsay Bezedlo and Mindy Poulter largely. And what we found is we did about 600 patients we tested for symptoms. We had 43 positives out of that 600 by PCR. We had 1 false positive that was negative by PCR, but positive by the antigen. And then we had 17 that were positive by PCR, but negative by the antigen. And so we had a sensitivity of about 60%, so much lower than what was in the package insert. And again, if you go back into the package insert, they talk about number of days of positivity. Last slide. And then I just wanted to mention that, so we have data on Sofia Quidel. There's also similar data coming out on the BD Veritor, which is, again, has an instrument with it, an automated reader. This is what's coming, and Virginia is expected to get a lot of them. And Dr. Roshheim is going to end up with what we're going to do with all of these and kind of outline where we think they should be used. But these are being distributed widely. So the federal government kind of doubled down on this and said, let's buy 150 million so that we can get more testing out and do repeat testing and test massive numbers of people. Remembering that massive numbers of people are usually asymptomatic, and that's not what this test was studied for. So for that test, just to review, the sensitivity is 97% in the package insert. But again, this was only based on 102 patients, remembering that we just distributed 150 million. So I anticipate that we are going to be seeing a lot more data coming out about the performance. And to me, the performance is critical about then, as we understand that, how are we going to use it and where are we going to use it and where is it going to be effective? So I think, as Dr. Roshheim is going to talk, I think that the guidance that's coming out now about where we're using antigen tests may be subject to change as we understand more about these antigen tests, because I feel like we're sort of building the plane as we're flying in it. So it's all coming very fast. That's it for me. So next slide.
If you want to go to the next slide. So this is Brooke Rossheim again. So one of the things that we did at VDH is we came up with interim COVID-19 antigen testing recommendations, and these were published last week. And then a clinician informed us that we had made a slight error in our table, so we updated it again on November 4th. So the first thing I wanted to do is to provide some general information about antigen testing. So all of the currently available rapid point-of-care antigen tests, of which they are all prescription only, so you need to have a medical provider order or prescription. The facility doing the test must either have a CLIA certificate of accreditation. So for instance, you might have a CLIA certificate of provider performed microscopy. That's fine. If you've got that, you don't need anything else. Or you might need to get a certificate of waiver. The facility doing the test has to have someone designated as the lab director. The staff performing the test must be competent to do so. And one of the things that I recommend is that they complete the manufacturer's training program. And like Amy, I don't have any preference over Binax Now, the Quidel Sophia machine, the BD Veritor, but all of them have little training programs that you can do they show you how to do the test, the nuts and bolts of the test, and that's very important. And that's also important documentation to keep. All test results, whether positive or negative, need to be reported to the health department within 24 hours. Next slide. So this is a table that is taken right out of the testing recommendations document. And so this is really sort of the centerpiece of the document. And I won't go through every cell, but what I want to point out is that if you have a situation where the patient's clinical picture does not jive with the antigen test, that's where you want to think about getting a confirmatory PCR test. So let me give you an example. So let's look at the far left-hand column. Let's say we have a symptomatic person who has a negative antigen test. Okay, if we have a symptomatic person, we're thinking that they might have COVID-19, but the antigen test is negative. So what we recommend is that you promptly isolate that person, you get a PCR test, and that while that PCR test is cooking, that person would remain isolated, and also that PCR test ideally would be obtained within 24 hours. 48 hours is okay, but we would really prefer it to be less than 48 hours. And if it's more than 48 hours, then there's some real question marks about the PCR test. The same thing goes for the opposite case, the far right-hand column. What if we have an asymptomatic person who is not a close contact to someone with known COVID-19, but that person has a positive antigen test? And so we're wondering, well, is this positive a true positive, or is it a false positive? And the way to answer that question is through a confirmatory PCR. And basically the same thing, that person would be promptly isolated. While we're awaiting that PCR result, we'd like that PCR test to be done, obtained quickly, and then we'll see what the PCR result is. And I'll let you go through the table because I think the table kind of speaks for itself. Next slide. So who should be tested, or, who should consideration be given to be tested with rapid antigen testing? Well, first, if you've got a symptomatic individual where COVID-19 is suspected, this is exactly who these tests were designed for. So they're definitely in. If you've got asymptomatic people who are close contacts to a known COVID case, they can be tested with antigen tests. And I've noted that, ideally, the testing should occur about a week after the last known exposure, based on what we know about the incubation period of COVID-19. Now, what about another area that we can use for testing is symptomatic and asymptomatic residents and staff in congregate settings, such as nursing homes, when you don't have PCR available, or when the turnaround time for PCR is excessive. So, for example, if you remember over the summer, there was such a crush of PCR testing that, testing turnaround times were 5, 6, 7, 8, 9 days. Well, that's not helpful at all. So that may have, that's a place to consider using antigen tests. And also not every place has ready access to PCR. So that's another consideration for an antigen test. And then the fourth bullet is probably the most controversial, and these are asymptomatic people who are not close contacts to a known COVID case, and they're in settings, again, where a highly sensitive test like PCR is not feasible or the turnaround times are excessive. And FDA has weighed in on this, and what FDA says is, in so many words, that we want you to use the most sensitive and specific test you have available. However, if you don't have that most sensitive and specific test available, i.e. PCR, then we're okay with you using an antigen test. So essentially what FDA has done is they've kind of broadened out that EUA for antigen tests. Next slide. And then these are locations where you can find the document online. So we put it in 2 different places. And next slide. And these are key resources that I went through the slide deck and wanted to give you a bunch of resources that provide a lot of good information about the topics that we talked about. And then next slide. Well, thank you for your attention. And next slide. And next slide. So I wanted to provide you also, we do have a couple of algorithms that are very nice, and I want to give thanks to our healthcare information team and our healthcare associated infection team for helping put these together. We have an algorithm for molecular testing, and the next slide. We also have an algorithm for antigen testing. And so these are an algorithm form of essentially what is in documentation that we have at VDH. And with that, I want to thank everybody for their attention, and we are happy to take your questions.
Thank you so much, everyone. We very much appreciate it. We're now going to open the floor for Q&A. If you could use the Q&A function on Zoom. That would be most helpful. And we'll just try to read them and go one by one and try to get to everyone's questions. So if you have any, fire them off. To Dr. Coffrin's question, is the slide deck available? Yes, this webinar is being recorded, and the MSV team will be sure to put it online on our COVID-19 website so everyone can access it. Any questions? Dr. Harry Gwanter asked, what are the recommendations for schools these days? Highly controversial topic. Who wants to take that one?
Rehab or Dr. Abdel Fattah, are you on the line?
Hi, can you hear me okay?
Yes.
Okay, good morning, everybody. I'm sorry, I have a technical problem with the camera issue, but for schools, I believe the common sense that I know that in the central region, there is a couple of districts, school districts are going back in full in-person classes, maybe next week. And personally, I don't work with a group that put some recommendation for schools, but as a parent, I know that schools are trying to take measures as much as they can. They implement screening kids every day before they come in. There is a form that children need to fill and complete before they go to school. It's in, I believe, in hybrid mood, and not all kids had to go same day. They are trying to provide alternatives, and like for social distancing, and definitely source control with masks is mandatory. I hope that will go fine. However, from the healthcare side, what we are seeing in communities with the increasing in numbers of cases nationwide, actually, we see that reflected in our healthcare system. We see increase in, as Dr. Elward showed, that there is increase in outbreaks reported in healthcare facilities, either inpatient or outpatient. And also that's reflected in long-term care facilities. With the holidays approaching and winter, I believe there is a lot that we need to be considering. We don't have, effective, maybe we don't have effective treatment or vaccine for now. However, we have to stick with the basic measures. And I hope that we will have an effective vaccine by the end of this year. I'm sorry if I don't have enough information, but I don't work directly with the school team.
No, I think I would support what Rehab mentioned. I do think we will really, this will be a global learning process, in that we have to look at other countries and see what they've done, how they've done it successfully, how they've not done it successfully. It's pediatricians and family physicians in particular are a little bit in a difficult situation at times when, our testing may depend on whether mom and dad can go back to work, whether they get, whether there are income issues that are going along. And we also have to say, is the test that we have assuring enough that I can safely send this kid back? an inaccurate test because it's quicker is not particularly a better test. On the other hand, we're faced with a lot of challenges. In the experience of other countries, particularly Sweden and some of the other Scandinavian countries that opened up fairly early and have had allowed school attendance, they have not seen a disproportionate number of problems with teachers getting sick or spread, particularly in the elementary grades. In the secondary school and colleges, or as they call some places, they call them gymnasiums, they'll have this seems like the spread is higher. So countries do different things, and I think we really need to learn about what they're doing right and what they haven't. Many countries opened up as of September, France and I think England and several other countries, and we'll have to see what they do, and maybe learn from countries like China and South Korea and Japan, where if they tell the kids to wear masks, they wear masks, and ours sometimes aren't as adherent. Yeah.
No, well, thank you. There was a question from Dr. Silverman asking, with cases and percent positivity on the rise, is the Commonwealth going to start thinking about whether to close restaurants, bars, and gyms? Dr. Rossheim got in the Q&A already and said it's probably not just yet. They're keeping an eye on it at VDH, including they're going to look at all of the relevant statistics, including percent PCR positivity rate and the number of outbreaks. But certainly, I think we can say that's on everyone's radar. The next question I had was, can anyone at VDH care to comment on the current contact tracing program in the Commonwealth?
This is Brooke Rossheim. I mean, contact tracing, it continues. It's a fundamental, part of outbreak response. So that, basically the idea is, once you identify a case, you want to find out, who the contacts are, because we have, public health guidance for them. And also we want to find out if the contacts are actually cases themselves. And so, then if we've got a contact that is symptomatic in a case, then, you've got to do the same thing for that person. So, all the health districts participate in vigorous case investigation and contact tracing, and obviously having testing available is key to this process.
Thank you. The next question comes from Kathy Scarbalis. New York State's implemented mandatory COVID testing for all of those folks who cross into New York State. What is the most appropriate test for this, in your opinion?
Amy, do you want to tackle that one?
Sure. So, we're not. So, is the New York State mandating testing or having everybody do testing? I think that we're going to be testing more widely. Obviously, we've got these antigen tests, and we're going to be testing more widely. I think that there's this tension between accessibility, usability, rapidness of resulting, and sensitivity, which are not, there's not a perfect test that has all of those elements to it that's then widely available. So, and I really think you have to think through the whole testing algorithm. Testing everybody that comes in. So now that we're getting more widely distributed tests, you have to remember, again, with the testing, just because you test negative on one day does not mean you're not infected. You could be early in infection, and sometimes right after travel, that's when actually you'd be highest risk. And so it doesn't get you off the hook. Like in the case that I gave, if somebody's exposed, you cannot test your way out of that. They have to still quarantine. They have to assume they're infected, and they have to monitor for signs and symptoms. And that's probably more effective in curtailing spread than testing everyone. I think that we're gonna see more widespread testing of asymptomatics, and I don't think we know what the performance is going to look like. There's some early data showing that it might not be as sensitive in asymptomatic persons, so even lower than potentially 60% sensitivity with the antigen test. So that might not be a very helpful test. And so most of the states that have required a travel document are requiring specifically a PCR test. So the antigen test may not get you there. And I haven't looked at all the different state guidances, but you can see why they do that. The availability of PCR tests is much more abundant compared to what it was midsummer. So that's a doable thing. But again, like Dr. Rosheim and I think Dr. Elward mentioned, the turnaround time is critical and you really need those results quite quickly. So in summary, I think that testing everyone repeatedly, although an attractive strategy, is not very realistic. And then with what test you would do that with, I think that's tricky, but there may be some really high risk situations where we'd want to do repeat testing with a lower sensitivity test to try to understand transmission.
So I'm going to jump ahead a question. Keith Frick had a question essentially saying college football teams, as you know, are getting multiple tests a week. You just alluded to it, kind of constant testing in other settings, such as school or clinics or hospitals. You don't think that's feasible or something we can do without, the Big Ten paying for it, basically?
Right.
See?
So yeah, I mean, and I think, so I was going to mention, like, the University of Virginia has had a really interesting experience in bringing back the university students. We had quite a bit of transmission. As soon as students came back, we had a policy of test everybody before they came back. People came back, but because there's that window period of travel and whatnot, we had quite a few new positive cases probably brought into our community from that. There were kids living in dorms, so congregate setting, which is high risk. And we repeatedly tested. We also used wastewater monitoring and several other things. But it was really, I think the thing that tipped it was that kids were really motivated to stay on campus. And so they whittled down, they enforced more strict masking, social isolation or social distancing measures, decreased crowd sizes. And I think that there was a pretty high level of adherence to that. And things got under control between that and repeat testing. So it can be done with all of those things. None of those things exist in a vacuum. And yes, the NBA successfully, I would say they were the most successful at doing it. The football has been less so. And the thing the NBA did was just created a bubble and then tested repeatedly to make sure nobody came into the bubble or no coronavirus snuck into the bubble. We are participating in college athletics and we do test frequently, and it's a lot of resources. And is that the best use of our resources? Because we do live in a world of finite resources, I think is up for discussion and debate at the state level.
All right, well, I'm going to combine two questions from Fred Fox and Michael Levine. Obviously, the holidays are coming up, both with Thanksgiving and Christmas. Regarding air travel more generally, what are VDH's thoughts? And then also, if folks are traveling to areas outside of Virginia, that might have higher rates of positivity or higher case rates, what would you recommend regarding quarantine or how to address asymptomatic colleagues or workers?
This is Brooke. I mean, it's if people are going, if people are going to areas where there are high rates of COVID. One of the basic things that we want to stress is that they follow good general preventive measures. So we want to make sure that they are, social distancing, washing hands, wearing masks, Another thing regarding that is if people, if people have been in sort of like an outbreak setting and then they go somewhere else, particularly if they're going to a place, sort of the example that I think of is if you're at a college that has an outbreak and you're going home to where that you've got a 90-year-old person who's got comorbid conditions, one of the things to think about, pretty seriously is whether to quarantine, and you're asymptomatic, is whether to quarantine for 2 weeks as a preventive measure when you get, because you want to protect the person, the elderly person, from getting COVID, because you've been exposed because you've been in a place where there's an outbreak, and this is a tough one because there are no hard and fast rules.